Greetings, ladies and gentlemen, honored guests. Welcome again on behalf of the members of BACA in collaboration with the Caribbean Medical and Scientific Association and the Barbados Nurses Association of America. I extend a warm welcome to each of you as you join us at the annual Deborah Brathwaite Symposium 2023. At the moment, I will present to you Dr. Edward Aline, who will give the invocation. Thank you.
Let us pray. Almighty and most loving God, we come before you this evening. We ask your continued blessings upon us, upon each and every one, upon the organizations that put this symposium together. We ask for the continued blessings of the speakers, the families who were afflicted by cancer, or any other illness. We come here empty tonight to be filled with knowledge and to share our knowledge through our expertise. And in the sharing and gaining, we hope that every word of this symposium will make an impact on some member, some family member, or some listener, that they will seek early treatment for any condition that they have, and that those conditions can be treatable, and in some cases curable if they are impacted early. We come not only for ourselves, but for the benefit of others, and for the doctors and nurses and healthcare professionals and the ancillary staff who make the team of the healthcare background. We ask that you continue to bless them, imbue them with knowledge, and that further research will someday bring a cure to cancer. We ask for the survivors, your blessing for the survivors of cancer, that they will be able to tell their story and make it more comfortable for those who are afflicted or those who have family members who are afflicted. We ask for this enlightenment, not only for ourselves, but for the Christ who saves us, who guides us, who loves us, and enlightenment. All this I ask for through Christ's sake. Amen.
Thank you, Dr. Aline. At the moment, I would like to introduce Honorable C.G. Mackey Holder, who will give a few remarks.
Good evening, everyone.
Good evening.
It's a pleasure to be here. Let me start by commending the Cancer Association in association with CAMSA and the Nurses Association for keeping the memory of Dr. Brathwaite alive in such a wonderful way. As I contemplated this event, this week we learned that the news anchor of News One, Rochelle Boone, who came to the United States at 11 from Jamaica, died at 48 from pancreatic cancer. I'm sure that we all would remember that we lost a former Prime Minister, David Thompson, from pancreatic cancer as well, at a very, very young age. Cancer, all kinds of cancers are among the most serious diseases in the world. And pancreatic cancer, I believe, has the highest mortality rate of all. I am told that you can live for a year, but I believe most people survive just mere months. So I think this is a very important session. The education about cancer is desperately needed, even though it is one of the most well-supported fights in terms of various illnesses that beset us all. So I really fully supportive of all actions taken by the Cancer Association and invite all to continue to support. I see that we have Dr. Laura from Barbados. I did recognize him earlier. And it is important that we share the knowledge. I was asked earlier this year by a young lady, why, having done all the good things, doesn't drink, smoke, any of the things that are supposedly contributors. How come she was just only a few months ago diagnosed with cancer? We all know that it is debilitating. And for those of us who have to confront that in our families and so on, it is equally devastating. And while I commend the work of BACA, which has been in existence for quite a number of years and has done wonderful work, not only through these sessions, but in practical support with equipment and so on to Barbados, I really want to also ask them to revisit what they did in COVID and keep sending out updates on new developments, new treatments, and so on, new possibilities that could possibly help those who suffer from this disease and those who are then left to make decisions on their behalf. I will listen intently as it's a learning process, and I look forward to continuing the support of BACA and pledge the ongoing support of the Barbados Consulate at New York. I thank you, and I'm sure we will have an enlightening, educational, and wonderful evening.
Thank you, C.G. Holder. At the moment, I would like to introduce to you Dr. Diana Callender, who is a clinical hematologist-oncologist. She's the moderator for our evening session. Welcome, Dr. Callender. Dr. Callender attended Queens College, where she won a government exhibition and went on to earn her medical degree from the University of West Indies Faculty of Medicine. After postgraduate training in clinical hematology, she was awarded a fellowship at the National Cancer Institute, where she completed training in clinical oncology. She has worked in Barbados, Dominica, and the US in clinical research and academic capacities. She has held professorships at Ross University School of Medicine and at the Geisinger Commonwealth School of Medicine in Pennsylvania, where she served as chair of the Department of Clinical Sciences and associate dean of simulation and simulated-based assessment. She has been a teacher and mentor to many students, an editor and reviewer, Journal of the International Association of Medical Science Educators. She has also been a delegate at several international workshops and summits regarding the status of women. She is now back in Dominica at the Princess Margaret Hospital doing clinical work and research. Dr. Callender moderated for one of our symposiums in 2021, in which today our main presenter, Dr. Harvey, also participated. Welcome back to both of you. Thank you.
All right, thank you. Thank you. And Dr. Harvey, it's a pleasure to introduce you once again. Dr. Harvey is a graduate of Harrison College in Barbados and graduated from the University of the West Indies Faculty of Medicine. After that, he went to Boston, where he did a residence in internal medicine, and then a fellowship in medical oncology at Tufts University Medical Center Hospitals in Boston. He joined the faculty of the Milton S. Hershey Medical Center in Pennsylvania at Pennsylvania State University in 1974, and has spent his entire career there, where he rose to the rank of professor of medicine and director of the Hematology-Oncology Fellowship Program. He has published more than 200 peer-reviewed articles. He has received several awards during his career, including excellence in teaching on more than one occasion, and for extraordinary patient satisfaction. The former is important in the formation of new clinicians, and the latter is central to the care of patients with cancer. He serves on several boards, including the American Society of Clinical Oncology Health Disparities Advisory Group, the FDA Oncology Drug Advisory Board, and the National Cancer Institute Board of Scientific Advisors. He is now Emeritus Professor at the institution to which he dedicated his career. Dr. Harvey will speak to us on pancreatic cancer. Dr. Harvey?
Good evening. It's a wonderful pleasure for me to be here and to have been asked to be part of this program. I didn't know Deborah Brathwaite, but I've learned a lot of things about her and her family. She clearly was a very wondrous lady. So it's my pleasure to be doing this talk in her honor. Okay, so what we'll do today is an overview of this disease, pancreatic cancer. We'll go fairly quickly, but I think, I hope we'll get the message very clearly. Let's begin by talking about the anatomy of the pancreas. It's a very special organ. It's about 6 inches long in an adult, and it has different associations with other parts of the human body. We talk about the head of the pancreas here, the body of the pancreas, and the tail. You see the gallbladder very closely related to the pancreas itself. So small intestine is shown here. And I want you to bear these in mind when we come to talk about individual cancers and how we're treating them. What about the function of the pancreas? What it does is to produce various enzymes and some proteins that help in breaking down and digesting food. So that's a very obvious plan of the pancreas. Another role for the pancreas is, as you will know, controlling blood glucose through insulin. Some people may not know that you can live without a pancreas. It'd be difficult, but you can. And we'll talk about this later, I suppose. Pancreatic cancer has a bad reputation. I will try and show you and compare with you what other cancers how other cancers compare with this bad kind of pancreatic cancer. What I want to end up telling you, though, is that we are making progress. Things are getting better. In the adenocarcinoma type of cancer, cure is uncommon, as you heard earlier. Unlike other cancers like colon or breast, where we can have patients who live for a very long time with this form of pancreatic cancer, the mortality, unfortunately, is quite high. When we see this disease in our patients, all too often, the clinical course is very short. But again, we can talk later about some progress. You might ask, why is pancreatic cancer so often lethal? And here's some of the things I think. The pancreas is located in the back of the abdomen. And when cancer grows in that site, it's hard to get to. It's a disease that's difficult to manage in a lot of instances. You saw in the picture that it's surrounded by many close by structures, and that complicates the problem in therapy. Sometimes patients present with symptoms that are very vague and or very late in the course of the disease. It's a cancer that spreads easily to local areas or distant metastatic sites quite early. So this is a little different, say, from colon cancer or breast cancer, where we have time to manage these patients, sometimes for many years. But with pancreatic cancer, there's rapid spread of disease very often. If you looked at the highest stage of pancreatic cancer, stage 4 disease, the average survival after that is about 4 months to a year. That has been how things have been until quite recently. Now, we talked about pancreatic cancer. 95% of patients who have cancer have this type of cancer called adenocarcinoma. So that's what we'll be talking about mostly today. However, there are some other cancers, and there's one in particular that I have been involved in studying, and this is neuroendocrine cancers or neuroendocrine tumors of the pancreas. It's about less than 5%. However, they are very interesting cancers. They secrete hormones, they cause flushing or diarrhea, or what you would call carcinoid. This is as I said, this is a malignancy that I've had some chance to study in the laboratory and in patients. Let me now talk about the epidemiology of pancreatic cancer, the kind of pancreatic cancer that we're most concerned with. In the United States, about third or fourth leading cause of cancer deaths. If you look in the behavior of this cancer, 90% of patients will die in 5 years. Very different from colon cancer or breast cancer. What causes pancreatic cancer? Well, we weren't very sure, but in the last 5 years in particular, there's been research that gives us a look at possible measures or possible causes of this cancer. Up until a couple of years ago, we did not think that alcohol played a role. There are some publications now, quite recently, that show that alcohol does play a role. Diabetes might possibly play a role, and we will talk about that a little later. I had the pleasure and the misfortune a few years ago of treating a young man from Ghana. He had bad pancreatic cancer, but he lived about 2.5 years. What I didn't know at the time, but later found out, a sister and a cousin and possibly his mother at a relatively young age also developed pancreatic cancer. So it's a disease that we have to treat with great respect. One of the things that so there are familial causes for breast cancer. One of the things we're learning is about genetics in this disease. For example, we now know that BRCA1 and BRCA2 mutations affect this disease. These are mutations that we think of in breast cancer, but now we're learning that pancreatic cancer can also be subject to mutations in BRCA1 and BRCA2. But this is a good thing because we're now developing therapies for this problem. Some of the therapies that we used in breast cancer, we are starting to try out in pancreatic cancer. Other causes are obesity. There's chronic pancreatitis also seems to increase the risk of pancreatic cancer. Smoking does to a certain amount. Recently, we learned that there are certain kinds of cysts, benign cysts of the pancreas, but they, while initially benign, they can in fact develop a bad behavior and contribute to pancreatic cancer. There is a suggestion that diet plays a role, and especially red meat in the diet. This clearly increases the risk of pancreatic cancer. Some of you mentioned earlier, and I certainly encountered it, of some young patients who developed pancreatic cancer, just like as we were seeing in some other cancers, like the colorectal cancer. More younger people are presented to us with these diseases. Mostly, though, the average age for this disease is somewhere in the 60s and 70s. As far as other risk factors, we now know that it is more common in Blacks, something that we see in a lot of other cancers. And similarly in males, they have an increased risk over females in developing cancer. I mentioned this unusual kind of cancer that I'd like to talk about, but we're not going to spend a lot of time on it. And these are neuroendocrine tumors. And they occur often in the small bowel or in the pancreas. And it's the ones in the pancreas that I've had a chance to do some research on. These neuroendocrine tumors are quite different from regular pancreatic cancer. Patients live longer with this kind of neuroendocrine tumor. And we have treatments now in the last few years for this kind of tumor. They're not simple chemotherapy, they're somatostatin agents. And in the last 2 years, there is a new program in which a radiation agent can be combined with a somatostatin agent in these neuroendocrine tumors, and patients are doing really well. You probably remember this patient. He had a neuroendocrine cancer. He eventually died. He died a little before we had the new therapy that I talked about. And this is, of course, Steve Jobs from fame that I think you would recognize. So let's go through some of the things that confront us when we start to manage pancreatic cancer. What about screening? Well, screening for this disease is not yet used in the general population. We can do it for colon cancer, or we can do it for breast cancer, but it's not being done yet for healthy patients there's no screening for it. The U.S. Preventive Service Task Force did suggest that there are certain times and certain individuals where we may want to do some screening. So any patients with the genetic syndrome that I talked about, BRCA1 and BRCA2, we are now testing these patients, pancreatic cancer patients, for BRCA1 and BRCA2 in males and females. For those patients who have a high risk and a familial setting, I think we should be screening those patients. I mentioned to you that cystic pancreatic lesions, if they develop a high-grade dysplasia, can progress to pancreatic cancer. So I think we should be screening some of those patients. A question I've gotten asked a lot from the residents and fellows, what about the issue of new onset diabetes? I think there's a risk here. I'm talking about patients who don't have a family history of diabetes, and very suddenly they develop symptoms of diabetes. And we'll talk about that in a little while. Let's move on to the signs and symptoms of this disease. The most common symptom is jaundice, what we call jaundice that occurs in the head of the pancreas. Another symptom that comes up fairly early is anorexia. So patients or individuals lose their appetite and don't want to eat. And this can be a symptom and a sign of pancreatic cancer. Abdominal pain is fairly common as time goes on over the few weeks to months. And weight loss is a very common symptom. You know, if you have anorexia and abdominal pain, you can't eat and you're not in a good mood, little reason to think that pancreas cancer is playing a role. There are sometimes changes in the skin and changes in the stool. In the skin, for example, you can get bronze in the skin or itching of the skin. And those are symptoms that your doctor should worry about. In the case of the stool, when the stool starts to get very clear, chalky, whitish, that is a bad sign for pancreatic cancer. One of the things I had a chance to work with other institutions a few years ago is the use of a tumor marker, a blood tumor marker called CA19-9, and we'll talk about that later. But I found that a very important and useful marker in pancreatic cancer. Now, there's some other symptoms and signs that are not that common, but I'd like to mention a few of them. You saw in the photograph, the picture, the relationship between the different parts of the large bowel, small bowel, and in the pancreas itself. When the tumor grows into the pancreas and gets into the nerves, this can be the cause of severe back pain. Another problem is blood clots. This is very common in patients with breast and pancreatic cancer as they progress. This is referred to as thrombophlebitis. There are instances where patients with thrombophlebitis develop what we call migratory blood clots, migratory thrombophlebitis. Trousseau in the 18th century recognized this. And this is a sign for a number of adenocarcinomas, but particularly the GI tract and cancer. As the disease progresses, especially at the head of the pancreas, patients develop what's called Courvoisier's sign. It has to do with the increase in the size of the spleen and especially of the gallbladder. I mentioned before that new onset diabetes that comes on very quickly in patients who didn't have the disease, that problem earlier. Whether it's the diabetes that causes the cancer or the cancer that causes the diabetes is questioned. I can tell you later what my view is. If all these things happen, the blood clots and inability to eat and so on, you would expect to find depression. A few years ago, we had at our institution a young man who was a psychiatrist, and then he went on to become an oncologist. And he made an interesting finding that in pancreatic cancer, there is depression, but there's certain features of the depression that are different from other causes of depression. He suggested that the pancreas was not secreting some proteins that the normal pancreas could, and that might explain the kind of depression, this deep depression that cancer patients with pancreatic cancer get more than other cancers like colon cancer or breast cancer and so on. So there's something there that we need to explore further. Let's say a word about diagnostic testing in pancreatic cancer. Mostly what we use once we're finding this disease is the CAT scans. That is the major test that we use. Another test is endoscopic retrograde cholangiopancreatopathy, ERCP for short. And that's, we use that a lot in diagnosis. At our center, our gastroenterologists are beginning to use endoscopic ultrasonography. So combining the effects of the both ultrasound and endoscopy, and making it easier to see how the cancer is growing, where it's growing, and that has been a very good measure of progress of this disease. There are tumor markers that I mentioned before, particularly the one I worked on, the CA19-9. Now, these markers, they're not for screening. These are for assistance in managing the patient. We will sometimes use MRIs, not a lot. PET scans are used, but again, not a lot. It's mostly CAT scans and endoscopic measures. Sometimes biopsies are used, as you'd expect, but sometimes we get tricked in biopsy in the pancreas because it's hard tissue and some of the cells that form the cancer are hard to find. Let's move on, I think, to treatments of pancreatic cancer. There's surgery, so we'll talk about the use and limitations of surgery. I'll say a little bit about radiation therapy for pancreatic cancer. And as a medical oncologist, I got to say something about chemotherapy. Actually, what it turns out as is getting more true is that we combine these modalities. Patients who can undergo surgery or need radiation therapy or chemotherapy, often now we're combining these modalities and we're getting better responses as a result. As you heard from our preacher a little while ago, palliative care is very important in this disease. So say a few words about surgery for pancreatic cancer in the past. We looked for patients where the tumor was not encasing major blood vessels like the superior mesenteric vessel or the portal veins, nor extensive nodes just outside the pancreas. Those patients have a better chance of being cured by surgery than not. A very common way of surgery is total pancreatectomy. Try and get the entire pancreas out of the way. That's why I mentioned to you that you can live without a pancreas. This pancreatectomy is also called a Whipple procedure. And it also has a longer name, pancreatic duodenectomy. And in the hands of good surgeons, this procedure can be done fairly well. but I'll come back to that. Sometimes we need partial resections, including the head of the pancreas, and we'll combine radiation therapy with that to help with slowing down the rate of progress of the cancer. Pancreatic cancer surgery today is changing. It's getting better. The techniques are robotic techniques and minimal invasive techniques. The one thing, though, that we are learning is that these treatments with very skilled surgeons are best done at hospitals that have a high volume of this kind of therapy. It isn't good to just have to do 5 or 6 cancer procedures at your hospital. You need an experience with many hospitals. So high volume centers are the best place for those patients. Getting back to minimal invasive therapies, the advantage for the patients are several. But for example, there's decreased blood loss. Patients get home very more quickly or earlier discharge from hospital. And these are the patients who have access to clinical trials. And as I mentioned at the very beginning, one of the things that we are involved with at our institution is to develop clinical trials with new agents in pancreatic cancer. Radiation therapy has a role. Very often, the radiation therapy is a complement to surgery. Or if you had nodes close to the main body of the pancreas, you might radiate those and try and slow down the growth of the cancer. Radiation therapy can also be used in pain management. As I mentioned before, this can be a very painful disease when the nerves get involved with a cancer. A word about chemotherapy. When I started in this field several years ago now, we had one drug to try and treat pancreatic cancer. And that drug was called 5-fluorouracil, 5-FU. It wasn't very good. A few patients did get some help, but we needed more. So then along came another drug called Gemzar. And what we did is to combine 5-fluorouracil with Gemzar. And then we saw patients get a little bit more time, although we needed better therapy nevertheless. So what we're now doing in the field, we are typically using combinations of drugs, sometimes 3 or 4, or there's one regimen with 5 or 6 chemotherapy drugs. The downside is that patients getting so many different kinds of chemotherapies have more toxicity. On the other hand, when we're doing this combination therapy, we're seeing patients now whose 5-year times are increasing significantly. And this is, I'll show you this in a minute. Here is a study that was presented at the last ASCO meeting. And the author from this meeting stated that this is some reason for optimism. So I have borrowed some of that information from him. So what they did is they looked at the stage of diagnosis, initial diagnosis of different cancer patients. So in patients whose disease was localized, 10% of those patients, or 10% of the cases, had a 5-year survival, a relative 5-year survival of 37%. Now, that's not calling cancer, but that's darn good now in pancreatic cancer. If you look at a second batch of patients, the regional patients, patients who had starting to spread in the pancreas, and just beyond, 29% of those cases had a 5-year relative survival of 12%. Now, if you look at the last two lines, the 53% of cases from distant disease and 8% unknown, they had very much lower 5-year survivals, 3 and 6%. So the interest here, and what we'll learn here, is that as with other cancers, but particularly what's happening now with pancreatic cancer, we need to identify the tumor at an early stage. The two tops did better and the two bottoms did unwell because the tumor was identified better in the patients in the first two lines I showed you. We need better treatments, of course, combined with this. But I think the author was right. There's reason now to start having more optimism than in the past. In summary, pancreatic cancer is still the nemesis, but we are making progress. We are learning more about the genetics and biology of this tumor, just as we have done with breast cancer, for example, or now colon cancer. We're a little bit behind, but there's a lot of research ongoing. There are more surgeons who are brave and very technically and adept, shall I say, using microsurgical techniques and robots. So they're doing more therapy than we did 10 years ago, more surgical therapy than we did 10 years ago. I mentioned to you that at our institution and others, there are newer chemotherapy agents now being tested. In addition to that, the combination of agents look as though they may give us a foot forward. Radiation therapy is now shows a greater precision, and we can radiate the tumor without damaging as much normal tissue as could happen in the past. Some institutions, not ours, is using proton beam therapy to establish that approach. We mentioned palliation, and attention to palliation is very, very necessary, especially for pain control or nutritional support. One of the things that we're finding out, not just in pancreatic cancer, but in other cancers, that exercise plays a role. That is interesting. And of course, spiritual support in these patients. Getting back to the issue of pain, one of the things that is being done fairly well and by many surgeons is celiac plexus blocks. This could be with alcohol or other chemicals. This can be done at the time of surgery for pancreatic cancer when it's clear that we can't do a good excision, but the patient's suffering pain. This can be repeated and is a way of supporting pain management along with the usual narcotics and so on that we have to use. There is an increasing growth about concerns for studies of pancreatic cancer. For example, there are places that called the PanCan patient services rendered to patients with cancer and their relatives as well. The Pancreatic Cancer Action Network does much of the same thing. There are a number of big institutions that are now getting more involved in pancreas biology and pancreas therapy. The cancer program at Johns Hopkins is very looking forward in that. Same at the Mayo Clinic and at UPMC in Pittsburgh, and where one of our colleagues worked at the National Cancer Institute. At NCI, there is a real attempt to do some new therapies and new trials in pancreatic cancer. So I'll stop there and hope that if you have any questions, I can answer them.
Dr. Harvey, thank you very much. I think a couple of the takeaways include looking at your behaviors in terms of diet, alcohol, obesity, remembering to talk to your doctor about your family history. Early detection, as with all cancers, is important. So have your annual checkup, but also if there's a change in your health, such as new onset diabetes, or changes in your weight or so on, you should speak to your doctor. If you're going to have surgery, it's best at high volume centers, which is a challenge for us in the Caribbean, but that is for a number of reasons, including accessibility and cost. And the fact that pain management is critical. The treatment with one of the things we are struggling with in our clinic now is treating the patients that we have in terms of the chemotherapy that's available, but its toxicity versus the quality of life sometimes. And then in terms of palliation, the pain management is critical on the role of exercise in cancer, to some degree prevention, and certainly in helping the management is becoming more and more, as is the role of spiritual support. In terms of what decisions the patients make and what their journey is like, we are fortunate to have Diana Cadogan, who is going to speak to us about a survivor's journey. Mrs. Diana Cadogan is a long-standing member of the Barbados Cancer Association, who has beaten cancer 3 times now, and is currently battling with stage 4 pancreatic cancer. She will share with us her story of survival and can talk to some of the issues that Dr. Harvey has mentioned. Mrs. Cadogan?
Okay. Hi, my name is Diana Cadogan, and I have been diagnosed with stage 4 pancreatic cancer. But before I tell you about that, please let me give you some background on my journey. In July 2007, I was diagnosed with stage 3 breast cancer, triple negative breast cancer. I've had to be treated very aggressively, they told me. And when I was first told I had breast cancer, it blew my mind. Prior to that, I had my yearly mammograms. I had never heard, and there was no one in my family that had ever had cancer. I ate well, I ate right, I was in good health, and even family members say, how did she get cancer? She's the healthy one. But I discovered a lump in my right breast, and immediately, and I'd had my mammogram 6 months before and nothing showed. I went to the doctor and I had to get a specialist. You know how everything is, you've got to get the referral. I got the referral. And when I went to him, he, put me through I got the mammogram, another mammogram, a biopsy, sonogram. And when a week later, I got back to his office and he said to me, Ms. Cadogan, you have cancer of the breast, but we can fix it. That's what he said to me. So my fear, I was no longer afraid. And from there, we went on to do, the various tests. I had a lumpectomy and all was well. I was introduced to the oncologist, and I remember him saying to me when he went over my medical records, he said, oh, very good. And I said, very good. So why am I here? If my records are so good, why am I here? And he said to me, healthy people get cancer all the time. So anyway, she went on to treat me, 8 bouts of chemotherapy, and then I had 35 rounds of radiation treatment. And I was fine for 4 years and 9 months. 2012, I had some discomfort with my eating. I had difficulty swallowing. I couldn't understand. I thought maybe I was having acid reflux, and I had this discomfort, and I decided I'd go see the doctor. But then they wanted me to see the GI doctor, I had to be a specialist. And of course, to see a specialist, I'd wait forever to get an appointment. And my daughter was with me at the time, and she said, "Mommy, I don't like this." And she drove me to the hospital, to the emergency room. And I was like, this is not an emergency room situation, but there was something about her that made me just say, okay, I'll do what she says. And we went to the emergency room, and there was a young doctor that saw me, and he just said, "No, it's not acid reflux, blah, blah, blah. There's something else going on here." And it was late in the afternoon, and he wanted me to get an upper GI series exam, but it was too late at that time. The technicians were all closing shop or whatever. So he got me an appointment for 2 days later. That was Thursday. And I got I went and I had because he wanted me to make sure I had got an appointment. He didn't want me to wait around and for somebody to tell me, 3 weeks from now or whatever. He was just very, very interested in making sure that I saw someone timely. And I got my GI, the test done, and the technicians looked kind of like something is wrong here, but they were all trying, how they try to act as if there is nothing happening, but I could feel that there was something more going on. And they told me I had to see the doctor and to wait. I saw the doctor and he said to me, "We are going to keep you for the night. We just have to find a room." And I'm like, "Find a room? What is wrong?" I wasn't really feeling sick. He said, "No, we've got to find a room, and we'll talk to you about it later. We want to run some further tests." So I was hospitalized. A battery of tests were run the next day. I had an endoscopy, all kinds of peds happening. And on the Monday, I spent the whole weekend in the hospital, and the Monday, a doctor came up, 2 doctors came. One was a GI doctor and internist, I guess, and a surgeon. And the doctor told me, "You've got the results of your various tests, and you've got cancer of the esophagus, esophageal cancer." And my thing to him was, who gets that? I don't smoke, I don't drink, how did I get that? He said, "We're not sure, but we're going to try." Again, there was a positive response from the doctor. We will try to fix it, basically. And I laid there in my bed and I teared up. I'm like, why? Another one, so the surgeon told me the process that I would go through to have surgery. He was going to cut this and attach this and appoint this and put this all back together. And he made it sound as if he was giving me a recipe to bake a cake, because I was like, this sounds very complicated. And but anyway, I got up the next morning, I went to bed, got up, and they arranged for me to leave the hospital and arrange then for me to start chemotherapy. I met the oncologist at that time. and they arranged for me to have this is 4.5 years after my breast cancer. I went through the process of having a port implanted and all that. And then the treatment was 5 days in the hospital for Monday. I went in on Monday mornings at 9 o'clock, and I started chemo treatment at 9 at night. And I would leave at on Saturday. And during that time, that 24 hours, the infusion was there for 22 hours, basically. 1 hour I got up to clean and take care of my body, and the other time I went down to have radiation treatment. And that lasted for 3 months, 3 weeks, 3 months. It was 1 month at a time. 5 days per month. I did that 3 months. After the fourth session, I went in as usual. I got, prepared, my blood, my whatever else I had to do. And I went into the hospital. They gave me my infusion that night. And the nurse that took my blood early in the morning, I think they came in like 5 o'clock and they took my blood. And then they came back at 7 and said they needed another sample. And by 9, the nurse said the attendant nurse said she had to disconnect my infusion, my tube, and the doctor will see me. And a few hours later, the doctors came up and they expressed to me that this medication had caused my liver enzymes to go through the roof, and they had to stop the medication. In my head now, I'm saying, if this thing that, if the medication doesn't work, what happens to me in this esophageal thing? I continue getting my the radiation treatments. I was sent home, I got the radiation treatments, and then at the end of the treatments, they did another endoscopy. And lo and behold, my esophagus was clean. There was nothing there. So I was very grateful at that point. There was no surgery needed. And I went on home. And I saw the doctor every 3 months. After that, I got endoscopies every 6 months, which was not the easiest thing to do. But I went through the process. That was it was every 3 months. The following year, June the following year, after my PET scan, I didn't discover, the PET scan discovered there was a lump in my left breast. And biopsied, yes, there was cancer, but it was not the same cancer I had in the right breast. It was, and because the right breast was the triple negative, the left breast was, I guess, the more simple form. And I was treated for that. Then my doctor said to me, this is your third diagnosis. Maybe, have you had a genetic test? And I said, no. They recommended genetic test, but at that time, I don't know, my insurance didn't really want to pay for it, because that was 2012, 2013. But anyway, he was able to arrange something, and I was able to get the test. Now, like I said before, there is no cancer in my family. And my grandmother lived to, everybody lived to be whatever. Nobody died of any of those kinds of things. And, everybody lived to be in their 90s and whatever, but I was the one, because like I said, when I said cancer, relatives were going, but we don't have cancer. We have blood pressure and we have sugar and that kind of stuff. And I was like, well, and the genetic specialist said to me, well, maybe you might be the first anyway, I went on and I got my treatment for my my third diagnosis for my breast cancer. The oncologist, oh, I love her. She said to me, this is 8, you're gonna need 8 infusions. And I said, can we just cut it down to 4? I've had so much of this stuff. She said, we'll see, how about 6? But we will monitor you and see. Anyway, I got the 6 after they looked at, I got all the tests and the blood tests and everything else. I was good. So we didn't have to continue anymore. But I was then put on that tamoxifen or whatever for 5 years. And that was not something that was done for the first cancer, because they told me that it wouldn't have helped anyway with that particular, with the triple negative cancer. And so I went on about my business, and I was doing well. I was in remission, doing well. I decided I wanted to do some of the things that I hadn't done. I did some traveling, and then I decided that, oh, maybe Barbados would be a good place for me to less stress and whatever. So in 2016, 2017, I decided I'll spend more time in Barbados. So I would go 3 months and come back to New York for 3 months. And I did that because I was still seeing my doctor every 3 months. I was seeing both the breast guy and the oncologist and the internist. I was seeing all 3 of those doctors on a regular basis. 2000. So I'm doing okay. I'm in remission. I'm doing all right. 2012, November, I started to lose weight, and I thought maybe it was a result of my eating, because I don't eat red meat. I don't eat a lot of stuff I didn't eat, and I thought I was doing okay. And I lost a few pounds. My daughter came down and she said, "Mommy, you're so thin. I don't even recognize it." I lost a good 10, 15 pounds, but I was still eating. But I thought of coming up to the doctor in December. I said, "No, I have a January appointment, so I'll just wait for my January appointments." And I came up. I came up in January, had my appointments with my GP. I had a doc, but I started to lose my appetite at this point. I wasn't eating, and I called the doctor, something is wrong. I was feeling discomfort in my stomach, not pain. It was just like an annoying discomfort, like indigestion or what. And took a little while for me to get a CAT scan. I had arranged to get my endoscopy, which I always got every couple of, now I was getting the endoscopy every 2 years because I was okay. And they arranged my endoscopy. And the same doctor that had given me the result for the esophageal cancer was the same doctor that was still there doing the endoscopies. He was one of the doctors that did the endoscopy. And he was like, "Hey, how are you?" Because they remembered me. Because one of the reasons they remembered me was because my case was so odd. I did not put it on esophageal cancer. It's because I didn't have, I wasn't a smoker. I didn't have any of those things that people usually attributed to people that got esophageal cancer. But with this now, when I came up here and I got the CAT scan, I knew something was wrong, but I truly did not think it was another cancer. I just thought there was something else going on with me. So in February, I was scheduled to go back to Barbados in February. And the week prior, I got the notice. I got a call from my doctor telling me, it was like the nurse said, "Doctor wants to see you tomorrow," because it was in the afternoon. I said, "Okay, I'll be there." And I took my daughter with me. Oh, by the way, my daughter is the best thing ever. we took the, we went over to see them, and as we sat in the waiting room, and they called me right away. We went in. This is at the hospital in the waiting room, and we went in. We sat, and she said to me, "We've got the results of your CAT scan, and you've got stage 4 pancreatic cancer. It has spread to your lungs." And my daughter just went. She just broke down, cried, and I cried because she was crying. And like the doctor said, pancreatic cancer. You hear the term pancreatic cancer, you think of your mortality comes into place. And she cried, and I cried, and the doctor cried, and the nurse cried. Everybody was in tears, and because the doctor that had performed the endoscopy, he came down too, because I was his patient, and he came into the room and he said, "I'm so sorry. I am so surprised you were doing so well," and blah blah blah, and through all that. And I just sat there like, oh my God, what's going to happen to my daughter? I wasn't even thinking about me in terms of that, because I just thought of my daughter losing me. And but what happened then? The oncologist, who's the same oncologist that I've had over the years, they had called her, so she called back the doctor, while we're in the office, and she spoke to me, and she said, I've got there's new medication, and I've got people living on, there's a pill that you can take, and I've got people that have been living with this diagnosis and living with this medication. So we're gonna do this, and so right now I've had to. They have told me that I would need 12 treatments, 12 infusions, but after my 4th infusion, they've decided that I would only need 8. I've had 8 infusions. I'm doing okay. I've started the oral medication. It's 4 pills a day. I am doing okay. I've got some difficulties, but I'm doing okay. So I've got the greatest support team in the world. I've got so many people supporting me. So I am grateful. I am very grateful.
Thank you so much for sharing that. This is an extraordinarily difficult time you've had. We will hold any questions. We are running a bit behind time.
Oh, wow.
Any questions we have for Dr. Harvey and from Sister Dublin after we hear from Ms. Sonia Clark. Ms. Clark is a member of the Caribbean American Medical and Scientific Association, CAMSA, who lost a sister to cancer. As Mrs. Cadogan just mentioned, the support of family and friends is really important in helping patients deal with the diagnosis, the treatment, and its effects. Mrs. Clark will tell us a little bit about her family's experience.
Hi, good evening, everyone. And first, yes, my name is Sonia Clark, and I lost a sister to pancreatic cancer in 2016. And a family's journey is pretty unique in that cancer affects everyone in the family. Even though you are not the patient, you practically become the patient yourself, because from my experience, and my sister's name was Etty, and it's Etty, E-T-T-I-E, and she passed, she also had breast cancer, and she was in remission, and then she developed pancreatic cancer. I don't know if there's any relationship between the two, but certainly it was a struggle for the family because she died at 60 years old. And when we found out that she had pancreatic cancer, she died within 6 months of having this cancer. And I spent those last 6 months with her. As a matter of fact, I heard her last words, which I wouldn't share with you because, you know, it's pretty private. But it was a challenge for I was the last of 5. She was the first of 5. And it was a challenge for my other sister and my 2 brothers, my dad, who was still alive at 89. My mom passed of natural causes at 85. And we don't have the history of cancer in the family. But for some reason, my sister developed pancreatic cancer. So it was hard first for her because you know, the stigma attached to cancer, especially in the Caribbean. Although she lived up here most of her life, she was still Barbadian, and she kept it a secret for some time until she couldn't keep it a secret anymore. And so she struggled, and we struggled with her. It was a real challenge to see my parents deal with her passing, because that was her, you know, she was their first child. So I would end by saying that similar to what Diana said, that the support with family is very crucial. We always remember my sister every anniversary of her death, and also for her birthday, because she was the eldest daughter and child, and she was like a second mother to me, because she practically wanted to raise me. So I would end by saying kudos to all of you who've, you know, spent the time here. And if you know anyone that is suffering with pancreatic cancer or any kind of cancer, please remember it is good to share, because you need that support. Because certainly, you know, we as a family, we struggled a bit, but then we came together to make sure that my sister was comfortable to the end. So I want to thank you.
Thank you so much for sharing and emphasizing that part of the role of the family and the effects on the family. We just have a few minutes for questions. I did not want to interrupt either Dr. Harvey or Mrs. Cadogan, because what they were sharing was so important. But Dr. Harvey, there are a couple of questions, I think they're a little bit related in the chat. One is, can you clarify what screening for pancreatic cancer involves, since the markers seem useful primarily for monitoring treatment? And then, in a sense related, does the cancer remain localized, and what are the factors that prevent early detection? So what prevents early detection, and what screening is there available at this time?
That's right. Screening for pancreatic cancer is not very practiced. We don't think we have good screening. What I was referring to are those particular number of people who have precancerous conditions that we know about, like some of the cysts that become malignant, so on. But it has been suggested by the UFT that we not use yet broad-scale cancer screening. It's not like breast cancer or colon cancer. So the screening I was referring to is for very special patients who we know have a high risk. What was the other part of the question?
Tumor markers.
Oh, the tumor markers, yeah. They're not for screening, but they're for managing the progress of the disease. There are ideas about trying to develop new screening techniques. For example, we can look at DNA from in patients, either circulating or in the tumor, and I think that's where I would guess in the next 5 years we're going to go. That would be the screen I would suggest.
Okay. The other part of the question was, what are the factors that prevent early detection? What are the Dr. Harvey, what are the factors that prevent early detection?
That's a good question. I don't know that I can answer that. But again, I think in the not too distant future, we will have answers for that sort of thing. And I think some of the biochemical as well as some of the genetic factors are going to be what we use.
And I think in terms of some of the factors is the fact of the location of the pancreas, because it is kind of behind other symptoms. And symptoms can be so vague, it's put down to indigestion or your diet, or so we tend to put off this. And I do think these are some of the factors, and because also, especially in our populations, diabetes is so common that with the onset of diabetes, we don't necessarily think to look further than the family history. So it is a very difficult disease to detect early.
No, I agree with what you were saying, yes.
It is interesting that the last two presenters both spoke about women with breast cancer who then presented with pancreatic cancer. And I was wondering, thinking back of your presentation, Dr. Harvey, about the BRCA gene and its relation. We know that there are so many things we have not yet identified as positive factors. What are your thoughts about this?
Well, one of the things I was sympathized with one of the speakers, a lot of patients or individuals don't get adequate genetics. I think we have to improve on that. And I think we'll find more cases of many cancers, certainly pancreatic cancer now, and obviously things like breast and colon. We are not using genetics as well as we should, in my opinion. I also agree with what you said about that often the symptoms are vague and you can put a finger on it easily, and so on. So it's a hard thing to, a hard thing to pick up at times.
I don't really see other questions in the chat. Yes, I just see the last question. Yes. Is there a difference between pancreatic? I'm not sure the question. It says, is there a difference between pancreatic / connection to stomach cancer? I don't know if the question is there a connection between stomach and pancreatic cancer that we know of?
I mentioned that 5% of patients who have neuroendocrine tumors, and the neuroendocrine tumor can be in the pancreas or in the small bowel. So these are different from the usual kind of pancreatic cancer we think about. That's why I showed you the pictures of Jobs, what's his name? Steve Jobs, and talked about the neurotherapies for that kind of cancer.
Is there any link that we know as yet between stomach cancer and pancreatic cancer?
Only, for my knowledge, only in the sense of these neuroendocrine tumors.
Different cancers. Thank you. Is there any? I think we have time for one more question or comment.
There was a question on the chat about jaundice in babies.
Oh, okay.
The jaundice you get in babies is entirely different from the jaundice that is associated with that pancreatic cancer. It's a different reason the babies get jaundice. So, and get over it. So it's not related.
So I have a question. This is, so you talked a little bit about in your presentation about the depression.
Yes.
And I would assume depression, stress are those some markers as well that can certainly add to the causes, or don't remember the terminology, but would those factors be considered, stress and
Yes,
depression?
they're being explored. For example, if you serotonin, which is one of the pleasure hormones, so to speak, and there are others. And a colleague we had working on this a few years ago, he suggested that what happened in the depression, specifically in pancreatic cancer, is that these hormones, these pleasure hormones, are not produced by the cancer. Now, the work is ongoing, so I can't say we absolutely know, but that seems to be a reasonable explanation for why pancreatic cancer patients get this extreme kind of depression. We're working on it.
Yeah, thank you. I think some of our takeaways from the session are in terms of the fact, in terms of trying as far as we can, the prevention in term, even though we have heard of experiences where things like doing quote unquote everything right, diet, exercise, eating, some people will go to a plant-based diet and so on, that even in the face of those, you do still develop cancer. However, it has been clearly shown that a number of these factors predispose to other cancers and obesity and all of these. So it is still very important that we live a healthy lifestyle. And the exercise is showing to be a more and more significant role, not only in preventing cancers and in helping when you're during the treatment and to keeping it away after treatment. In addition to that, we talked about the key role of the support of the cancer patients by the family. And I think one of the very important roles was when Mrs. Cadogan said, "I love my oncologist." I think this is where we started in introducing Dr. Harvey, when I made the point that his exceptional patient reviews were a critical part, because the healing power of the physician in such a difficult situation can't be underestimated. I would encourage any medical people listening to take that as a takeaway as well. Okay. I would like now to introduce Dr. Cecily Wilkinson. Dr. Wilkinson is the president of the Barbados Nurses Association of America and is a retired healthcare executive with an enduring commitment to promoting health equity. She will give the closing remarks. Dr. Wilkinson.
Good evening, everyone. Thank you, Dr. Callender. We are truly thankful and honored to continue the symposium in honor of Dr. Deborah Brathwaite, who was an advocate as it related to cancer. The members of BACA, CAMSA, and BNAA would like to say thank you to her sister, Dr. Gail Brathwaite, and relatives for their continued support. Dr. Brathwaite will be forever in our hearts. Thanks to the president of BACA and vice president of CAMSA, Margaret Dean, for her hearty welcome. Thanks also for Dr. Edward Ali, president of CAMSA, for the praise. For we all know with God, all things are possible. And yes, Diane, all things are possible. Keep on thinking positive. Thanks to our Consul General, the Honorable Matthew Holder, who reminded us of one of our prime ministers who succumbed to the pancreatic cancer. He also requested that BACA continues to share updates regarding cancer treatment. Thanks to our very lovely moderator, Dr. Callender, who once again present us with her presence. She is trained in clinical oncology. So she did a very good job of tying in with Dr. Harvey and what he was saying. So truly we are thankful to you. Dr. Harvey is a distinguished physician and an expert on the topic of oncology. He's not a stranger to this group because he previously also was a speaker. He spoke of the anatomy of the pancreas. So I guess some of us on this call who are not healthcare workers will need to go to the library and do some reading. He spoke of the anatomy of the pancreas. He spoke of the body, the head, and the tail. The pancreas produces enzymes to break down food and also controls insulin within the body. We are making progress. However, the anatomical position of the pancreas makes it difficult at times. He also shared some statistics. 95% is adenocarcinoma. He also spoke of the 5% of the neuroendocrine tumors within the body. Dr. Harvey shared the epidemiology of pancreatic cancer. It's the fourth leading cause of death. 90% of patients die within 5 years. We heard about BRCA1 and BRCA2, which are some of the risk factors and the genetics marking. We also know about the alcohol, obesity, smoking, and the diet. So I guess we all have to think of some life changes. The average age is between 60s and 70s, and it happens more in the Black males. And we all know that for our culture, Black males are hesitant to attend the doctors at times. Screening for pancreatic cancer, he shared some of the information with us. He also shared some of the signs and symptoms, example, jaundice. And again, someone asked about babies, but again, the baby jaundice is completely different. That can be cured with putting the babies under the light for a period of time. Anorexia, loss of appetite, abdominal pain, and weight loss are some of the changes that we see for the pancreatic cancer. So he gave us some of the therapies also that is present for pancreatic cancer. So we need to keep up to date about the various therapies within for pancreatic cancer. So Dr. Harvey, we are very thankful for your presentation, and I hope you will be available for us again in the future. We heard from Diane Cadogan's survival journey. And as she said, her family mentioned she did all the right things and she was considered the healthy one in the family. However, she got cancer. So wanting to know is Diana's positive attitude through the process. She's now in stage 4 pancreatic cancer, and we need to keep her in our prayer. We heard from Sonia Clark, who is the assistant treasurer of cancer, about her family journey. She said her sister died within 6 months of pancreatic cancer. And they spoke about the various stigma that sometimes is attached to cancer. But we need to share the thought that there shouldn't be a stigma attached to cancer. Anyone could have cancer. As we know, the Prime Minister of Barbados had cancer and Steve Jobs had cancer. So we need to get rid of the stigma. Family support is very crucial. And I will say that I've had many friends with cancer, but the ones that shared the idea that they had cancer and they had family support and friend support, they survived longer than the ones that wanted to keep it a secret. Last but not least, I would like to thank the planning committee and also the technical committee. And we have to especially thank our technical committee, who's Sonia Clark, Janelle Taylor, and Daniel Ross, and also Dr. Paris, who was the lead for the planning committee and did plenty of the work for this symposium. We also thank all you who registered to join and give of your time this evening. We do acknowledge the topic of cancer can be difficult for some. However, we are urging you to continue conversations with family and friends regarding all types of cancers. The diagnosis of cancer is difficult and scary for some. Please pray for each other and offer support wherever possible, not only for the diagnosis of cancer, but for other diseases and illnesses also. Thank you and have a blessed evening.